Let's hear from Dr. GAURAV LUTHRA. He is again a very high volume phaco-refractive surgeon and a high volume ICL surgeon from Drishti Eye Center, Dehradun. All to you, GAURAV.
Thanks, Sonu. Actually, it's not running from my laptop. They are doing it from there, so I'll just try to do whatever I can.
Can you help, please? Can you just coordinate? Yeah.
So I'll see if the video plays. I don't know. I think there's no point doing it. I'll just call it off here.
Start it.
Anyway, this is some video. I can't see it here, so I'll have to just look there and tell you. This patient was, okay. In fact, let me just see if I can. I think Grover has gone crazy this time. So this patient was an ICL patient. We've done a 3 mm incision for injection. This wound sometimes will not seal perfectly and it will be a leaky wound. You can't suture them because you've done a toric ICL. So if you have a ICL situation where you have a leaky wound, instead of suturing it, you can just make this supraincisional small pocket and hydrate it, and then you can actually get a very good seal on that, so you don't have to suture them. Now this is another patient. This sometimes happens with IPCLs. I don't know if I can play this video. Let's see. Okay. So this happens with IPCL sometimes. You put in an IPCL very nicely and goes very easily. Actually, the injection is very much easier than even with the star ICL. So it's much easier for surgeons who are used to doing phacos and IL injections. So once it is positioned nicely, you can you think that the job is over, but sometimes the job is not over there, and you can see that the haptics go in very easily. So it's not a oversized or any other kind of a situation here. Now, once you've done it, you should wait to see that the pupil, even though we don't use pilocarpine nowadays anymore for all our surgeries, yet you must wait to see. I sometimes increase the illumination of the microscope, and I wait to see that the pupil covers the edge of the optic. And you can see here that it's almost there, but I notice that sometimes if you have a slightly higher vault, the iris will start going behind the optic of the lens. Now, if that starts happening, you can't leave it like that because it will just keep a self-perpetuating kind of a situation. So it's always great to observe till the end. And now I've put a little bit of pilocarpine and made sure that one of the sides is covered now. And then I'm waiting for the other one, but it is not. And usually these vaults will settle down post-op, but these patients must be kept on watch. Sometimes later on when you dilate them, they will still have a optic which is caught on the pupil. So this can happen with IPCL sometimes and does not happen so much with the star ICL as I've seen except one patient. So going on, I think I'll just go on to something more interesting. Let's see, because there's almost little time left. But sometimes you'll have a first eye where you get a low vault ICL, and then you can always change it for the second eye to the higher vault ICL. But what do you do for the first one? Now, if it's just like a vault which is not too low, you can still carry on because with the central flow now nothing much happens. So if it's like 100, 150 microns vault, but if it's like a 50 microns, then you'll have to do an ICL exchange. So somebody was asking what kind of forceps you will use. So best thing is to just use the ICL holding forceps itself, which is best suited for this. You can hold the ICL from one of two places. Either you can hold it from one of the haptics, or you can hold it between the two haptics as you would hold it while loading the lens. Nowadays, I like to hold it just from one haptic and pull, and a 3 mm incision. It just kind of twists and comes out. So this is a very old video, so you'll see my old forceps. This was almost 10, 15 years back, I think. So the ICL, and here probably I'm holding it from between the two haptics. So nowadays, there are better forceps available, and even the MST IOL holding forceps is very good. So ICL comes out very easily and can be re-injected. Let's see if I have any other thing. Yeah. Sometimes, end of the OT list, you have an ICL posted, the pupil constricts, and that time you have a situation, so you don't have to abandon the surgery. You can just put phenocaine and it works quite well. So this patient came into my OT towards the end of the OT for an ICL. I think I think we'll stop here because you can just put phenocaine and complete the surgery over there. So I think we ran out of time. You can just inject phenocaine. You can see how fast the pupil is expanding, and within about 10-15 seconds, you can proceed with the surgery. So I think everybody has already covered most of the things that were required, so I'll just stop here. Thank you.